My name is Edward Kenneth Rodriguez. I go by Ken Rodriguez. I'm the Chief of Orthopedics at Beth Israel Deaconess Medical Center. I've been an orthopedic trauma surgeon for about 20 years. I would like to talk to you today about minimally invasive acetabular and pelvic fixation. I have no disclosures that are relevant to the present topic, so we will get right to it. What is percutaneous fixation? Well, it's the fixation of particular types of acetabular and pelvic fractures using minimally invasive techniques. Now, these are usually different types of columnar screws or supraacetabular screws that we insert into the pelvis using thoracoscopic guidance, or in some cases, navigation type systems, but you really don't need a complicated navigation system to do these techniques. Mostly, you need to understand the anatomy and maybe have a basic type of fluoroscan. Here's an example of how pelvic fracture, in this particular case an acetabular fracture, looks like after you've applied columnar screws. This particular x-ray shows two supraacetabular screws and one anterior column screw to treat a fracture in a very geriatric patient. There are many issues that people question sometimes about this technique. Early on, it was initially controversial, but it has very much become a standard of care for many fracture types. The outcomes can be a bit variable, depending on what type of fractures you're addressing, and you really have to be careful about having proper indications. Some folks have criticized the approach because they say it works when you're fixing fractures that maybe didn't need to be fixed and would have done well anyway. And there is a degree of truth to that, but for example, when you're using it for geriatric patients, it may allow early mobility, and even though it's a fracture that under other circumstances could have been treated non-operatively, it is beneficial to the patient. But I agree, proper patient selection is critical. There are several advantages to using these techniques. It's an alternative for fixation in patients that are hemodynamically unstable or have other injuries or have severe comorbidities, or who can, for one reason or the other, tolerate an open reduction internal fixation or some type of hip replacement surgery. It tends to be a very quick technique once you develop the skill to do it. There is very little bleeding, and it really offers very good pain control for patients who would benefit from early mobility, but who cannot undergo extended fixation. A lot of older patients who have fractures that are not very displaced, but that are limiting their mobility, sometimes putting a screw or two will stabilize the pelvis enough that they can actually get up earlier. It's useful for stabilizing minimally or non-displaced patients and fractures in patients who are very elderly, but there are also some techniques that I will show you that will allow you to reduce fractures that are a bit more displaced. Some of the difficulties with the technique, well, it's only applicable really to anterior column fractures, transverse fractures, T-type fractures, and cervical alar fractures. It's not really very helpful technique when the fractures are very displaced. Sometimes it's difficult to achieve that reduction, and it does take a bit of a learning curve until you at least learn the views. The understanding the thoracoscopic views is the hardest part. You need to be a little bit careful not to get carried away with the indications, particularly as you're learning. The indications at our institution are mostly focused on the frail elderly patient, when the only other option is non-operative care. When perhaps you can tolerate a bit of a less perfect reduction, it's a good technique to stabilize a pelvis before a hip replacement or at the same time. It allows early mobility and improvement in pain control, and it's really the only option when the only alternative would be bed rest or some form of traction. When dealing with younger patients, our indications are focused on fractures that are minimally displaced or that can be reduced well, fractures that are non-displaced and at the weight-bearing dome in patients who are not compliant for cognitive or behavioral issues, or also in patients who cannot tolerate pain and would otherwise be bedridden. And it's also an option when traditional open reduction internal fixation is not possible for whatever reason. I once had a patient who had a kidney transplant, and the kidney transplant was exactly located where the ilioinguinal exposure would have taken place to address an acetabular fracture that was subsequent. That patient I treated with percutaneous technique in order to minimize potential damage to the kidney transplant, which would be a very terrible complication. So the instruments we use are actually quite straightforward. It's essentially a tray of cannulated screws, usually bigger ones such as a 6.5, 7.3, or 8.0 millimeter screws with their guide wires and appropriate insertion devices. So the key to the technique is really to understand your radiographic fluoroscan views and to know how to use the CM very well. Most of these are combinations of iliac oblique, obturator oblique, inlet, and anterior to posterior views. I think you should practice before you start to get these views and potentially even help yourself by drawing some directional lines on the skin as you start looking at the pelvis with different inclinations. A little thing I always encourage my residents to think about is these theorems of spatial geometry. So if you're working on the convex side of a surface, that is, for example, in a hip, the acetabular side of the hip, think about how many CRM views you would have to get to properly identify that no line intersects the surface. So these lines intersect the surface, right? This line now doesn't. So if you can just get one view where the screw is outside the joint, you are fine. Conversely, if you're working on the concave side of a surface, let's say the femoral head side of the hip, if you were doing maybe a percutaneous spinning, how many CM views showing that you have not intersected the surface do you need to demonstrate proper non-penetration with 100% certainty? Like, this line doesn't look like it's crossing the joint, but you don't know because it's a curved surface. This one, it doesn't look like it's crossing it, but what if it's further behind and it's outside? So the reality is that you need infinite views. So the nice thing about working on acetabular fractures with percutaneous techniques is that you're working on the convex side of the joint. So when you put your screw, you only need one view showing that the screw is not tangent or touching the joint to have 100% confidence that you are not penetrating the joint. So here's some of the examples of fractures you can treat with these techniques. You can certainly treat the rami fractures and anterior column fractures. And there are a lot of examples of this. It's probably one of the easiest screws to apply. And you just have to determine the appropriate bony corridor. And I usually use a 7.3 or a 6.5 millimeter screw for this type of fracture. I'm going to go now and illustrate my first example. This is a young man who is 18 years old, who fell from 5 stories while at a party, has many other concomitant injuries that are not relevant to the hip, but has a splenic laceration and has an open lateral pelvic wound with some exposed iliac crest, a scapular fracture, and has a minimally displaced anterior column fracture at the 45-degree roof arch. Let's look at some. So here's an AP pelvic view of this young man's fracture. You can see the fracture right here, and you can see we are inserting a guide wire in a retrograde manner. This is an inlet view, so as you insert the guide wire, you have to make sure you're in the anterior column. You switch between the inlet and the AP or outlet views to guide your guide wire eventually in the direction that you want, which will be this one. Here we are back into the AP view with the guide wire in place, and you can see the drill that's going to over drill the guide wire to insert the screw. And here's the final image with the screw in place across the fracture and into the entire length of the anterior column. Let's look at now at an example of a posterior column fracture. So the posterior column screw can be done in an antegrade manner or retrograde manner. I usually do these screws in an antegrade manner by doing a mini lateral ilioinguinal window and finding the entry point on the inner table of the pelvis. Some folks do this in a retrograde way by flexing the hip and entering the pelvis through the ischial tuberosity. Transverse fractures can be treated with a combination of anterior column screws and posterior column screws. It's a combination, that is, of the two examples that I have just illustrated. Let's take a look at a second example. In this particular case, we're dealing with a 15-year-old female patient that was hit by a car and dragged. The patient has deformities of the leg, multiple abrasions over the back and extremities. And this is a picture of her pelvis. You can see there are quite severe issues here. On one hand, the hip appears to be dislocated, and there appears to be, at a first glance, what looks like a transverse acetabular fracture. So what happened to this patient? Well, this patient also happens to have a femur fracture, and then there's a bit of a three-dimensional reconstruction of how the whole thing looks like. You can see the anatomy of the transverse fracture a bit better here. Here's the posterior aspect of the pelvis with the transverse fracture component. So the patient was close reduced at the hip, and the femur was plated, and then we had to deal with the acetabular fracture. And now we are in a situation that's a little bit more manageable. You're dealing with a very discrete transverse fracture. Here's the anterior column component, right? And you can see how it goes towards the back. And here's the posterior column component right there. So now we're going to plan this a little bit better and kind of try to understand what the bony tunnels are, because this is a pediatric patient who's 15, so maybe we need to use a bit of a smaller screw. Sometimes with pediatric patients, you can't fit a 6.5 millimeter screw, and you have to do something even smaller. So we took this patient to the operating room, and there's a little bit of an offset here at the transverse fracture. The anterior column appears to be slightly medialized compared to the rest of the acetabulum, and you can see how a guide wire would look going through there. But then you can make a small incision through the ilioinguinal exposure and use a cob to press and reduce a bit more as you pass the guide wire. So as you're pressing, reducing that a bit so it looks better, you can then insert the wire, and then over the wire you insert the screw. And you can see in this case that we have a view where the screw appears to be very almost tangential and potentially harming the joint, but then when you look at other views, it's a bit better. And now you can see in this image how from the upper part of the image, the guide wire that's going to delineate the introduction of the posterior screw is inserted. So again, through the small ilioinguinal window, the entry point of the antegrade screw is identified, and then the guide wire is inserted. This here is a iliac oblique view illustrating how the guide wire is going to miss the joint in its direction towards the ischial tuberosity. This shows the wire as we have advanced it past the joint. And we are now going to insert the screw, which will miss the joint in its direction to the ischial tuberosity. And insert the screw, and this is how the screws look. So now you have here the posterior column screw and the anterior column screw, and that case is now stable. So you can also use this technique for high anterior column fractures. These are anterior column fractures that break into the iliac crest. And you can actually insert these screws through the anterior and inferior iliac spine, directly posterior, perpendicular to the fracture, and aiming towards the posterior aspect of the iliac crest. Let's look at some. Here's an example of an 85-year-old patient who has many medical issues. It's a vasculopathic patient. He's on dialysis, has had multiple grafts and bypasses in the ilioinguinal area. The patient is at best a household emulator and unfortunately has fallen at home and sustained an injury that looks like this. So here we're looking at a AP pelvis, and you can see there is an anterior fracture component with these little green arrows that goes all the way from the margin of the crest all into the joint. And it's thankfully fairly non-displaced, but the patient's 85, is a large fracture plane, is having a lot of pain, is not going to mobilize very well, and leaving this patient in bed for several days or a couple of weeks before they can even move is probably not a very good idea. So this patient is a good candidate by our criteria to be treated with percutaneous fixation. So what we do, we take the patient to the operating room and we start looking at the views. This is a view that delineates this area where the instrument is marking that is called like a teardrop area. You obtain this view by coming over the patient in a bit of a obturator view, and also tilting the head, tilting the CM a little bit distally. So it's a combination of an obturator oblique and a outlet view. And you will see, if you do that, you will see the area of the bone tunnel where the screw is going to go through. This is the guide wire placed through straight into the tunnel, so you're looking at its smaller projection. This is now converting to the iliac oblique view. You can see the guide wire going from in the supraacetabular area all the way back into the iliac crest. And over that wire, you can then insert the screw. This is a view where there is a combination of obturator oblique with a bit of an inlet view that allows you to see the screw going into the posterior aspect of the iliac crest towards the posterior iliac spines. And you can do a couple of screws fit very easily. So you can put two parallel screws that go across the anterior columnar plane that extends proximally. This here again is the view that we started in. Is this combination of obturator oblique with inlet that shows the tunnel where the bone goes in, and you can see the two cannulated screws much in parallel going straight into the bone. Once those two supraacetabular screws are applied, then I think we have the opportunity to put an anterior column screw like we've illustrated before, and we can pass our wire across the anterior column proximally, traversing the anterior column part of the fracture, and there goes the wire into the more proximal part of the acetabulum. It goes, it entirely misses the joint, and over that wire you can then insert a screw, so you now have a final construct that looks like this. So this is again a bit more of an AP, a little bit outlet view, showing the anterior column screw and the two supraacetabular screws. And this is how it looks at the very end. So you have two supraacetabular screws going from the anterior inferior iliac spine towards the back of the iliac crest, secure the major anterior column fracture that extends into the crest, and then an anterior column fracture to increase the stability. This is the obturator oblique view of the construct, showing the anterior column screw and the two supraacetabular screws. And now I'm going to show you the iliac oblique view that of the same construct. You can see the two supraacetabular screws going essentially across the entire front to back length of the iliac crest. Let's look now at a fourth example. This time we are going to be dealing with an 18-year-old younger patient who was hit by who had a high-speed motor vehicle accident, otherwise healthy, but has significant pelvic pain and inability to mobilize. This is the AP pelvic view, where you can see the fracture defined. This essentially, it's not particularly an acetabular fracture, but it's a fracture of the iliac crest and the rami. So this is a pelvic fracture, probably an LC2, lateral compression type 2 pelvic fracture with a large crescent piece. Here are the CT scans showing the fracture breaking through the upper part of the most proximal part of the crest. Here's a fracture seen with the CT scan a bit more distal, where you can appreciate the large crescent fragment that is still attached to the sacrum via the posterior sacroiliac ligaments and the fracture plane that we need to address. We're going to repair this using starting with an anterior column screw. So this is the guy wire as it goes in using the obturator oblique view. We carefully advance the wire, switching from the inlet view to the obturator oblique view to make sure we are inserting it into the intraosseous part of the anterior column. We then advance the guy wire proximally, and you can see how the guy wire is external to the acetabulum. It's in the convex side, so we are not going into the joint. While the wire is in place, we do a small lateral window of the ilioinguinal exposure, and we apply a clamp to maneuver the proximal aspect of the fracture into reduction sufficiently to insert a screw along the margin of the crest in an anterior to posterior manner. And here's the guy wire already in place. We are now going to do a third guy wire. This is going to be a supraacetabular guy wire. This view here is a combination of the obturator oblique with an inlet view, where you're seeing the entire iliac crest in a single plane, and you can insert the screw anterior to posterior using this imaging and making sure that you're in bone and making sure that you actually capture the crescent fragment at the top of the image. You can see here how we are advancing the guy wire. It's going to go in this direction all the way proximally. And at this point, the guy wire has traversed the crescent fracture plane. This is now a lateral view of the whole setup, and what we're doing here is we're identifying the body of S1 right here, because we're going to have to insert a sacroiliac screw as well. So this is an inlet view where you can see our anterior column screw here. You can see our supraacetabular screw that's going to go over that wire. There's a screw up here that you can't see it, and we are now inserting a guy wire into the body of S1, where we're going to be inserting the sacroiliac screw. This is the outlet view. You can see the foramens of S1 here, and make sure that the wire goes proximal to the foramens. So you're switching back between the inlet and outlet views to secure the proper sacroiliac screw fixation. After you've inserted the guy wire into the body of S1, you go back and forth a couple of times, and here's again the inlet view demonstrating proper guy wire placement. So now that all our guy wires are in place, now we start inserting the cannulated screws. The first one going in here is going to be the sacroiliac screw. The sacroiliac screw is now in place in this inlet view. We are now over drilling the screw that's going to go along the the iliac crest. So here's an image showing that we now have the sacroiliac screw and the iliac crest screw in situ. Now we're going to over drill the supraacetabular screw that goes from the anterior inferior spine all the way into the crest in this direction. Again, this is a combination of an obturator oblique with an inlet view. Here's the screw being drilled across the whole length of the iliac crest. Here's where the crescent fracture used to be. And here's the screw in place. So you now have your sacroiliac screw, iliac crest screw, anterior to posterior supraacetabular screw, and we're now going to put in the anterior column screw. We're now over drilling the anterior column screw over the first guy wire that we applied. This is an inlet view. This is the screw going into place. And here is finally the complete construct. So as before, we had the rami fractures, right? we had the crescent component of this lateral compression pelvic fracture. This is the little staples reflecting the small ilioinguinal window we did. This is the screw that fixed the upper part of the crest. This is the front to back supraacetabular screw. The anterior column screw is here, and the sacroiliac screw is in place. And we have restored pelvic integrity in this young patient. This is the same patient, of course, but we are now showing the outlet view just to illustrate that the S1 screw is clearing the foramens, which are noted right here. And finally, we are now showing a inlet view of the same patient, where you see your sacroiliac screw, your anterior to posterior screw, your crest screw, and your anterior column screw. So in this case we just presented, we actually made use of a sacroiliac screw, and that's a very common screw, perhaps one of the most common. It's a screw that we use to repair a sacral ala fracture or a sacroiliac joint dissociation. The main risk is to the L5 root, which lies in front of the sacral ala, kind of around here. So you have to make sure that you have the proper guide wire insertion before you put the screw. Our last example is example of an older patient with severe osteodystrophy and very low bone density. No real history of trauma, but the patient comes in presenting with very painful sacral insufficiency fractures. Was actually on a table getting a sacroplasty procedure when the actual fractures were noted, and then that procedure was aborted and the patient was sent to us for some type of fixation. This is a AP pelvic film, and it's not very apparent just from this x-ray what's going on. There is no obvious acetabular or pelvic ring injury, but you will see that there is some insufficiency fractures of the sacrum. Let's go to the next image. This is a coronal view of an MRI, where you can see the sacrum with a lot of signal change on the bilateral aspect of both sacral ala. And this is very typical of fractures in patients who have severe osteoporosis, which we refer to as insufficiency fractures. Here's a transverse section of the CT scan, which shows the fractures a bit more clearly. You can see these fractures here. So this is a bilateral sacral ala insufficiency fractures in a severely osteoporotic patient that has a lot of pain and is completely unable to mobilize. Now, if it was one or the other, or a patient who was perhaps not as osteoporotic, and if it was a traumatic fracture, we see tons of these lateral compression type sacral alar fractures that require absolutely no treatment. But this one was a particularly burdensome set of injuries for this patient. One thing you have to be a bit careful is that if you look carefully at this image, you'll see that there's also a bit of a transverse component of the sacrum. So now we are dealing with a transverse component, fracture component of the sacrum, and two vertical sacral ala. So this is a light case, frankly, of potentially an H-type sacral fracture, which carries a risk of progression and sacropelvic dissociation. So how do you treat this? Well, you could get very complex and do lumbar iliac fixation, or you can try to stabilize at least the vertical planes of the sacral ala fractures with a percutaneous screw that goes entirely across the pelvis. That is the approach we took on this particular patient, who is not a very mobile patient but has too much pain to even sit. We performed a sacroiliac percutaneous fixation using a screw that's going to go entirely across the sacrum. So in the typical manner, we use the inlet and outlet views to determine the safe passage of the guide wire, missing the foramen, and Then we insert the screw. This AP view illustrates a screw going across the entire width of the sacrum. There's good cortical purchase in the insertion side of the sacroiliac joint, but we also catch the cortex on the other side. This obturator oblique view shows that we purposefully breach the cortex of the ilium so that we can have a good cortical grip at both sides. So to summarize, percutaneous fixation is a very standard technique for many pelvic and acetabular fractures. The goal is to achieve as close as anatomical reduction of the articular surface of an acetabular fracture that you can, and stability of the pelvic ring. It is a very useful way of fixing fractures when extensile approaches are avoided for some reason, and it decreases hospital stay and morbidity in the elderly patient who cannot, for some reason, have a formal open reduction internal fixation. It is important that we keep the indications clear. The indications for acetabular fractures are anterior column, posterior column fractures, and transverse fractures. Occasional a T-pattern will be able to be fixed in this way as well. It is important that you understand your fluoroscopic images and how to get them. And if you have fluoroscopic navigation technology, that could certainly be useful during the learning curve. Thank you so much for your attention. I would like to acknowledge my colleagues at the Department of Orthopedics at Beth Israel Deaconess, who allowed me to use some of their slides as well. Thank you for listening.